Hello, I'm Joe Berger, a professor of neurology and the associate director of the MS division at the Perelman College of Medicine at the University of Pennsylvania. And I'm going to talk today about the role of B cells in progressive MS and the long-term effects of B cell depletion. Our learning objectives are to explain the most recent advances in the understanding of MS immunology based on the latest science in order to initiate and sustain appropriate treatments. More specifically, we're going to talk about anti-CD20s and their role in progressive MS and the potential consequences of their use. I show this slide to remind the audience that 80 to 85% of the patients that we initiate disease-modifying therapies on have relapsing remitting multiple sclerosis. And we have a laundry list of medications currently that are of varying efficacy in the treatment of relapsing remitting MS. This is not as much of an unmet need in the treatment of MS as that for progressive disease, depicted on the following slide. Now, in the absence of therapy from historical data, within 10 to 15 years of the onset of relapsing remitting MS, 50% of individuals went on to progressive disease. That number appears to have declined with the availability of effective therapies. And I should hasten to add that there is a small group of people, perhaps 10%, that first present with progressive multiple sclerosis, never having had an acute active event that would be considered a relapse. We cluster progression into two separate categories. There's progression that is the consequence of disease relapse. So an individual has an event and then never fully recovers from it, leaving them with a fixed deficit. And that goes by the acronym RAW. It's worsening that occurs as a consequence of a confirmed relapse. And then there's progression independent of relapse, otherwise known as PIRA, which is worsening that occurs in the absence of relapse activity, as we see in primary progressive disease. Progression may occur with either RAW or PIRA, or with concurrent RAW and PIRA. The laundry list that I referred to of medications really begins in the early 1990s with the approval of interferon beta-1b. And now we have more than 20 drugs. I've circled the 3 drugs that are available that are anti-CD20 monoclonal antibodies approved for treatment in multiple sclerosis, at least by the FDA. In the blue above the line are the FDA-approved drugs, and the orange below the line are those approved by the European Medicines Agency. And you'll see that there's a third that's been recently introduced called ublituximab. It, like ocrelizumab, is an infusion, whereas ofatumumab is an injection therapy. Now, it's interesting that anti-CD20s work. The historical model of MS immunopathogenesis largely dependent on T cells, the thought that T cells were responsible for disease activity. And that is likely incompletely true. And in the slide that I borrowed from my colleague, Dr. Amit Bar-Or, you see what has been regarded as MS immunopathogenesis, the historical model, in which there's activation that occurs in the periphery, and then these activated cells will adhere to the endothelium in the central nervous system, get attracted, invade, and then attack the myelin within the central nervous system. That may be true for a large part with respect to relapsing remitting multiple sclerosis, but clearly the pathogenesis of progressive disease has to be different, because you can effectively block the sequence of events and it does not have any effect whatsoever on disease progression. We have historically also attempted to categorize our drugs in terms of their safety and efficacy. And this is but one of many publications in which this has been addressed. This comes from a network meta-analysis. It's an exercise that sometimes physicians, particularly key opinion leaders, are asked to perform. And it's more based on personal opinion than it is necessarily on hard data. But you will see that anti-CD20s like ocrelizumab are regarded as relatively safe and highly effective. The story of the value of B-cell depletion in relapsing remitting multiple sclerosis dates to a publication in the New England Journal in 2008, in which a phase 2 trial using rituximab in this condition demonstrated a remarkable reduction in inflammatory brain lesions and clinical relapses shortly after the drug is administered. This was somewhat of a surprise, given what we know or thought we knew about disease pathogenesis. The authors of this study suggested a number of potentials for the mechanism of action, but admitted that the predominant mechanism responsible for the improvement in disease activity was largely unknown. They recognized that plasma cells were not targeted by rituximab and that total antibody levels were not significantly reduced after a single treatment course. And therefore, the rapid onset of action that they observed was unlikely to be explained by a reduction in pathogenic autoantibodies. They proposed that perhaps a better explanation was a lysis of memory B cells located in peripheral blood and lymphoid tissues, or perhaps in the central nervous system itself, and suggested that there may be other mechanisms, such as interference with antigen presentation by B cells, or with activation of T cells or macrophages by pro-inflammatory B cell cytokines, such as gamma interferon and interleukin 12. However, there have been other possibilities that have been raised subsequently. And these alternative hypotheses include the possibility, although not widely adhered to, that the effect of the anti-CD20 is actually on T cells. There appears to be a very small population of T cells that bears CD20 receptors. This amounts to about 3 to 5% of the total CD3 T cell population. And perhaps these have a very significant role in the pathogenesis of multiple sclerosis. An alternative explanation that has been proposed is the elimination of Epstein-Barr virus-infected memory B cells, as we've learned increasingly about the importance of Epstein-Barr virus in the genesis of multiple sclerosis. In the initial studies looking at ocrelizumab, an anti-CD20 monoclonal antibody that was specifically designed and studied in individuals with relapsing remitting multiple sclerosis and primary progressive multiple sclerosis. In the initial studies, in which it was studied in relapsing remitting MS, labeled OPERA-1 and OPERA-2, ocrelizumab 600 milligrams every 24 weeks was compared to interferon beta-1a 44 micrograms subcutaneously. When they performed a pooled analysis from this data, they found, quite interestingly, that disability progression at 12 weeks was significantly reduced. And that held true for disability progression confirmed at 24 weeks as well, as one sees in the graphs on the left of this slide. Interestingly, they also found that there was a disability improvement, a confirmed disability improvement at 12 weeks in the ocrelizumab group compared to the interferon beta-1a group, but this was not quite as robust as the decrease in the rate of disability progression, confirmed disability progression. The effect on ocrelizumab on the rate of confirmed disability improvement was significant only in OPERA-1. It was not significant, interestingly enough, in the OPERA-2 trial. Observing that there was an effect on disability progression and disability per se, it was only logical to perform a study of ocrelizumab in primary progressive multiple sclerosis. This was published in 2017, and what it demonstrated was that ocrelizumab was associated with lower rates of clinical and MRI progression than placebo, which was the comparator in this particular study. And if one looks at the graphs from this study with respect to 12-week confirmed disability progression and 24-week confirmed disability progression, one sees that there is a difference in the slope of these lines, with the gray representing placebo and the blue ocrelizumab. Now, the disparity between these lines is not enormous, but they were statistically significant. Similarly, when pooled analysis was done with the injectable form of an anti-CD20 available to us, namely ofatumumab, similar reductions in progression were seen. So what one sees in this particular slide is that 3-month progression independent of relapse activity was significantly different with ofatumumab in comparison to teriflunomide. And this was true as well in the secondarily progressive MS group with respect to 3-month progression independent of relapse activity. So the conclusion in this study was that ofatumumab significantly delayed the time to first 3-month confirmed PIRA versus teriflunomide in all subsets of patients. However, when they looked at the 6-month data, they were able to confirm similar findings with respect to PIRA without confirmed relapse, but that did not hold true in the secondarily progressive MS group. While there was a risk reduction, as you see on the right of this slide, it did not meet statistical significance. And the conclusion was that ofatumumab delayed time to first 6-month confirmed progression independent of relapse activity versus teriflunomide in all subsets of patients, but it was not significant in the subset of secondarily progressive MS patients without confirmed relapse. What are the risks of anti-CD20 monoclonal antibodies? And these are the contraindications, the warnings and precautions taken from the package inserts of ocrelizumab and ofatumumab. One of the contraindications to the administration of the drug is active hepatitis B infection. What is known from the use of rituximab in different populations than the MS population is that you can reactivate hepatitis B, and that can lead to very serious disease. And the other is a life-threatening infusion reaction that occurs during the course of administration of an anti-CD20 monoclonal antibody. The warnings and precautions include infusion reactions, infections, and it is recommended that one delay therapy until after active infections resolve, and to avoid live attenuated or live vaccines until B-cell repletion occurs. With respect to malignancies, an increased risk of malignancy may exist, but I'll have more to say about that in a little while. With respect to risks with anti-CD20 monoclonal antibodies regarding infections, there's a higher proportion of infections in individuals on ocrelizumab in comparison to interferon beta. It's slight, but it appears to be real. Recall that beta interferon is an antiviral, but even when compared to placebo, there's a slight increased risk of infections, chiefly viral upper respiratory infections. But there does appear to be a slight increased risk of other viral infections, including VZV and herpes viruses. With respect to PML, which you will find on the label, it's worth exploring what we know about PML with rituximab. So rituximab has been used in a wide variety of diseases, chiefly rheumatologic diseases and B-cell malignancies. And it's been used for a much longer period of time than any of the anti-CD20s for multiple sclerosis. If one looks at, as has been done, the data from the global safety and clinical databases for the rheumatologic indications that are approved by the FDA for rituximab, and they are rheumatoid arthritis, granulomatous polyangiitis, and microscopic polyangiitis, through November 2015, one sees really no increased rate of PML over time. And one sees that there are confounders in all instances, and the number of cases of PML that can be attributed to the addition of rituximab to the therapeutic regimen in these diseases appears to be very small. The same appears to be true with the use of rituximab with B-cell malignancies. So PML occurs in non-Hodgkin's lymphoma and chronic lymphocytic leukemia in the absence of the use of B-cell depleters. But when you use rituximab, the rate increases approximately 5 times. However, in the study that was performed, and I was one of the individuals that conducted this study, almost all instances, these patients were also treated with other drugs that increased the risk of PML, including bendamustine and fludarabine. The estimated incidence of PML with rituximab use in this particular population still remains quite low at about 8 per 10,000, so significantly lower than what one sees with natalizumab in MS, for instance. And what we found was that the rituximab PML incidence was low and remained stable over 20 years. We also found that most of the individuals who had rituximab-related PML in this population, mind you, a very different population than the MS population, died within several months of diagnosis. And in conclusion, rituximab PML in non-Hodgkin's lymphoma and chronic lymphocytic leukemia remained a rare event, even in people with high risk of PML from these disorders. What do we know about PML risk with anti-CD20 monoclonal antibodies in multiple sclerosis? So it looks like prior anti-CD20 experience, as indicated, does suggest a slight increased risk of PML. However, there's no significant increased risk over the time of treatment, at least in the rheumatologic community. There's, as I mentioned, a slight increased risk with hematologic malignancy. PML is rarely observed, if ever, when rituximab is used for neurologic disease. So many of us treat patients with CIDP, myasthenia gravis, and paraneoplastic disorders. We've yet to see rituximab associated with PML in this population, at least to the best of my knowledge. There are, however, a handful of cases of PML that have been reported with ocrelizumab, and one that I am aware of with respect to ofatumumab. Almost all these cases are carryover cases, meaning they had been treated with drugs that predisposed to the development of PML before the initiation of the anti-CD20 monoclonal antibody. There are only 2 cases that I'm aware of in which that was not the case. So that the risk of PML with anti-CD20 monoclonal antibodies is extremely low, probably on the order of 1 in 100,000 or thereabouts in the MS population. With respect to malignancies, this has been looked at with rituximab, where we have a much longer experience. And what's been demonstrated is that there does not appear to be any significant risk with rituximab for malignancy in any population. And when you look at the data with respect to multiple sclerosis, one finds from, for instance, the Swedish registry, that there was no increased risk of malignancy with rituximab when compared to natalizumab or fingolimod in the MS population. From the ocrelizumab pooled analysis in 11 clinical trials, there was no increased risk. And that included looking for non-melanoma skin cancers and for breast cancers. And from the Danish MS registry for breast cancer, there was no evidence that ocrelizumab or anti-CD20s increased the risk of breast cancer. With respect to infectious diseases, we've been quite concerned about the effects of anti-CD20 monoclonal antibodies on COVID-19. And it does appear from aggregated data that there is a slight increased risk of more severe infection in a small percentage of the population treated with these drugs. And the data is a bit conflicting. It appears that rituximab may have a more marked effect than ocrelizumab, and ocrelizumab may have a more marked effect in this regard than ofatumumab, there being no data with ublituximab, which was only recently released. But in one study, it was found that rituximab was associated with an increased risk of hospitalization, ICU admissions, and the need for ventilatory support, whereas with ocrelizumab, there was a slight increased risk of hospitalization and ICU admissions with COVID-19. One of the potential explanations is the effect of these drugs on antibody response, and has been shown in a number of studies, most importantly, the Veloci study, the response to vaccinations, be they antigens that you had been previously exposed to or neoantigens, appears to be blunted following the administration of these drugs, and that shouldn't be surprising. So in this particular study, they looked at ocrelizumab 3 months after infusion and compared it to placebo or interferon beta. They compared a tetanus toxoid, influenza, pneumococcal vaccine, and keyhole limpet hemocyanin, which is a novel neoantigen. And they looked only at the humoral response and found that it was attenuated, but they believed that it was sufficiently protective. What's been demonstrated in subsequent studies looking specifically at COVID-19 responses is that the humoral response does appear to be attenuated. However, the T-cell response, which is a very important response in controlling viral infections, probably more important than the humoral response, is unaffected. And some studies suggest that it may actually be greater than one would anticipate otherwise. The recommendations from the National MS Society regarding COVID-19 vaccination, and this is true of any vaccination, is really to get fully vaccinated at least 2 weeks prior to the start of an anti-CD20 monoclonal antibody. And if you're already on therapy, to get vaccinated approximately 4 weeks before your next scheduled infusion. With respect to ofatumumab, which is an injection that one receives monthly, the recommendations are a little different. Obviously, get fully vaccinated at least 2 weeks prior to start, but there's really no good data to guide the timing of vaccination once you're already on therapy. And the suggestion is to consider the vaccination 4 weeks after the last dose. In an effort to connect science and good clinical practice, anti-CD20 monoclonal antibodies are safe and highly effective for MS. They should be considered as first-line agents in all patients with relapsing remitting multiple sclerosis. They have a measurable, albeit modest, effect on progressive disease in the absence of relapses, and humoral vaccine responses may be diminished following their administration, and timing of vaccination relative to their administration may be helpful with the infused agents. There are a number of unanswered questions. Among them are the following. Are there meaningful differences regarding efficacy between available anti-CD20 monoclonal antibodies? If there are differences, to what can it be attributed? Can we predict individuals at higher risk for infection with anti-CD20 monoclonal antibody treatment? What is the long-term safety of anti-CD20 monoclonal antibodies? And like other cell-depleting agents, such as alemtuzumab and cladribine, may anti-CD20 monoclonal antibodies be discontinued after a period of treatment? These and other questions remain to be answered. The key takeaway messages are the following. The mechanism of action of this class of agents in multiple sclerosis still remains uncertain. These drugs are remarkably effective in relapsing remitting multiple sclerosis, and as I mentioned earlier, should be considered first-line treatment in any patient. There's a measurable effect on disease progression in this population. There's an increased risk of hepatitis reactivation and viral upper respiratory infections with these agents. The humoral antibody vaccine response may be reduced following their administration, and the safety of long-term effects of these agents in the MS population still remains to be determined. And I thank you for your attention.